So the anatomy of the respiratory system. We have two basic zones. We have a conducting zone and a respiratory zone. So the conducting zone is characterized by the trachea, the bronchus, the primary and the main bronchus, the bronchi and the bronchioles. Basically, the role of these areas is to conduct air from the atmosphere into the diffusible portions of the lung. So it's here in the conducting zones that no gas exchange occurs. It's basically conduit vessels for transport, warming, and humidifying and filtering of the atmospheric air. As you begin to get down into these transitional and respiratory zones, so you get into the bronchioles, the alveolar ducts, and the alveolar sacs, all the way down through multiple generations of branching, you get into these respiratory zones, which is where the site of pulmonary gas exchange is. This is where the alveoli and the pulmonary capillaries come in touch with one another, where carbon dioxide and oxygen are exchanged. So a healthy lung has a massive gas exchange, a surface area for gas exchange. So if you probably heard this, if you were to take the average lung and lay it out as a single cell layer, it would cover about half the size of a tennis court. So it's a massive surface area for gas exchange. So the lung is generally considered, so basically lung, the airways, so the diameter of the airways, big and small, the respiratory musculature, as well as the surface area for gas exchange are generally considered overbuilt for the capacity of even recreational or relatively fit individuals to consume oxygen, produce carbon dioxide. The lungs are a very, very efficient exchanger of gas. They're not necessarily a weak point in the oxygen transport chain. Now that's not an absolute statement, because in disease, emphysema, pulmonary fibrosis, bronchitis, severe asthma, lung cancer, various other conditions, neuromuscular disorders, and muscle weakness, it can become a very substantial impairment or weak link in the chain. But for basically anybody in this room, the lungs are generally considered to be overbuilt. So, if we talk a little bit about mechanics of ventilation, we often think about the balloon in a bottle experiment. Okay? So here we have a circumstance where we have the atmospheric pressure of about 760 millimeters of mercury at sea level. So the respiratory control centers are in the medulla, they're in the brainstem, and there's many multiple receptors, but that's basically where the hub of the respiratory control center in the central nervous system is located. And it's these medullary signals that send neural information to the major muscle of inspiration, which is the diaphragm, which reduces the intrapulmonary pressure. So it'll reduce the pressure within the lung below that in the atmosphere. So because gas moves from areas of high pressure to low pressure, when you create a pressure gradient for flow, air will literally get sucked in along the pressure gradient into the lungs. So at the onset of, and in breathing, you get this phrenic nerve activity. The phrenic nerve innervates the diaphragm. The diaphragm, that dome-shaped muscle right underneath the lungs, will contract and descend. So imagine that basically you're pulling this balloon that's attached with the lungs in the bottle, you're pulling it down. Okay, so you're creating a negative pressure within the intrathoracic space, which will cause the lungs basically to expand. And so air will be sucked into the lungs along the pressure gradient. So the diaphragm descends during contraction, the intrapulmonary pressure will drop, say to 754 millimeters of mercury, and create a pressure gradient. And air will then move from the atmosphere through the conducting zones of the respiratory system and into the lungs, and the lungs will expand. Pretty straightforward. So we have multiple muscles of inspiration. Some are what they call obligatory muscles, and some are kind of supportive. So we have the diaphragm, which is really an obligatory muscle of inspiration. It's the major muscle of breathing. It's responsible for about 75 to 85% of every breath that we take at rest. We also have the internal and the external intercostal muscles, so the rib cage muscles that will help to pull the rib cage up during inspiration and create some of the negative interthoracic pressure or interpulmonary pressure, particularly when the diaphragm is burdened. So if you need to basically lift the rib cage and create that negative interpulmonary pressure to suck air into the lungs. Imagine now you had either due to diaphragmatic weakness due to prolonged mechanical ventilation, or you had some type of respiratory mechanical abnormality that caused the diaphragm to be very short due to things that we call lung hyperinflation. So remember, length tension relationships of the muscle, right? The muscle has an optimum length tension relationship where it generates a lot of force. If the muscle is too long, it's weak. If it's too short, it's weak, right? It has basically an optimal relationship where the actin and myosin are overlapping. So if you take the diaphragm and the diaphragm gets too flat, it becomes weak. So if the diaphragm becomes weak in a bad pressure generator, you have to basically recruit the accessory muscles to try to help lift the rib cage and create a negative interpulmonary pressure to allow for inspiration to happen. So we can have this coordinated effort, but these are considered accessory muscles of inspiration, which is to say that they're active, but they're not primary. And then we also have these upper, so we have the scalenes, which are important, in the sternocleidomastoid. If ever you come to my lab and spend some time in my lab and you see a patient on a mouthpiece exercising, say a patient with chronic obstructive pulmonary disease, what you will see, even in a healthy individual, is you won't see a lot of activation of the scalene in the sternocleidomastoids. But what happens is that when patients with chronic lung disease or interstitial pulmonary disease, when their diaphragm and their inspiratory muscles become short and weak, you need to begin to activate all of these upper neck muscles to really try to lift the rib cage. So what you see is these patients often, as they're going, that's the way they breathe. So the diaphragm is doing everything it can, the external and internal intercostals are doing everything that they can, and it's still not enough. So their SCM and their scalenes are just firing away. And they're just trying to get that rib cage to lift and create some negative pressure for inspiration. So they become activated, particularly as the major muscles of inspiration become loaded and weakened, which happens with disease and can happen with heavy exercise. So the inspiratory muscles basically act to flare the rib cage and create a negative intrapulmonary pressure, which again will drive air from the atmosphere along the pressure gradient into the lungs. Pretty straightforward. Expiration, in contrast to inspiration, which is active. Expiration, at rest at least, is generally passive. The lungs are elastic, the rib cage is stiff, so when the lungs expand, everything basically wants to recoil back to its relaxation volume. So, elastic recoil model that we talked about previously. An elastic structure stretches, it now has an elastic recoil force that wants to return to its resting volume. Okay? So, fortunately, expiration is passive in the most case. At rest, it's a passive event. And again, we're generating pressures that move air along pressure gradients. So, during inspiration, lung inflation will actually increase the activity of what they call pulmonary stretch receptors. So within our lung parenchyma and our airways and our tissues, we have these what they call slowly and rapidly adapting pulmonary stretch receptors that will respond to the rate of lung inflation as well as the magnitude of lung inflation. Basically, they're sensors that prevent us from breathing our breaths that are way too big. So as we begin to breathe in and our lungs begin to expand, these stretch receptors, as their name implies, will begin to increase their firing rate. And these are actually inhibitory receptors. Keep this in mind. They inhibit inspiration. So the more active a stretch receptor becomes, the more inhibitory activity it's sending information to the brain to say, all right, you're breathing in, you're getting a bigger breath, you can stop breathing in now. Does that make sense? So they're like a brake. As the stretch receptor increases, it's saying, okay, you're stretching, you're breathing in, you don't need to breathe in as much anymore because now it's sending that information, all right, stop inspiring, your lungs are stretched, begin expiration. So these pulmonary stretch receptors will send basically neural information and inhibitory signal to the brain. These pulmonary stretch receptors will result in a progressive turning off of the neural signal for inspiration. This is what they refer to as the Herring-Brewer reflex. So basically the extent of lung stretch, so you can do this in animals, it's much tougher to do in humans, but if you mechanically ventilate an animal, and then you put an electrode into the phrenic nerve of the animal, so you measure the descending motor drive to the major muscle of inspiration, which is the diaphragm, you can find is that as you have dynamic and static lung inflation and activate the stretch receptors, you will actually get a dose, basically a dose response decrease in phrenic motor output. So the more the lung stretches, the more of an inhibitory signal for inspiration there is. This is what they refer to as the Herring-Brewer reflex. Right? So at rest, the passive recoil of the lungs at the end of inspiration of the chest wall, combined in combination with the ascent of the diaphragm, will increase the interpulmonary pressure now above the atmospheric pressure. So now it might rise to say 764 millimeters of mercury, and this will push air out of the lungs along its pressure gradient. During exercise, expiration becomes more active because now we need to move air into the lungs at a faster rate. So we can't just rely on the passive recoil of the lung and the chest wall. So now what happens is that the expiratory muscles, the abdominal muscles and various other muscles that I'll show you on the next slide, they become more active, almost acting like a corset. So what they'll do is that as they become active, they will basically kind of squish the lung tissue, creating a greater pressure, a more rapid change in pressure to force air out of the lungs at a faster rate. So think about almost like a cough, right? A cough is maybe not a great example for exercise, but it's a good example for a concept of expiration, right? So you have to activate the abdominal muscles on a cough, correct? So if you don't really have a very forceful flow rate, right? It's not coming out, but if you air moves out very, very quickly. So the extent to which you can activate your abdominal muscles will dictate the rate of airflow along the pressure gradient. You create more positive interpulmonary pressure with a greater activation of the abdominal muscles, you will get a faster rate of expiratory flow. So during exercise, particularly heavy exercise, the expiratory muscles have to become recruited. They have to be actively engaged to support the expiratory flow requirements, to get air out of the lungs fast enough, beyond that which is just going to occur by passive recoil of the stretched lung and the stiff chest wall. Okay? So, the muscles of expiration include the internal intercostals, the external obliques, and various other, the transverse abdominis, the rectus abdominis, and again, on their contraction, they basically act as a corset. So they will serve to kind of compress the lung, increase the interpulmonary pressure, and drive air out through the conducting airways, out through the conducting zones of the respiratory system. So, inspiration is active, expiration is passive. Now, on inspiration, coming back to the elastic recoil model, we have lungs that again are within a rigid chest wall and they want to recoil. So immediately you have a circumstance where you would have to work, every breath has to occur against some elastic recoil. Right? So, if you ever go to the gym and you have the bands, the resistance bands, so if you have a light resistance band, there's not much of a recoil, right? It's like basically the curl that you're doing is against the recoil force. If you get a really rigid band, you have to work really, really hard against the recoil force. So try to think of that in the context of what the work is being done. Is if you have to get a really stiff band, you have to generate a lot of elastic force to basically overcome that resistance, overcome that elastic recoil. If you got a thin band, almost like a normal elastic band, it doesn't require much elastic work. You don't have to overcome much of the elastic work. So every breath that we take has the potential to require a lot of what they would call inspiratory elastic work. Because every breath that we take would have to work against the lung that's trying to recoil and the rib cage that's stiff. This has huge implications for the way that we breathe and why we breathe during exercise the way that we do, and we'll get into that. So this is a lot of text, but over the normal physiological range of breathing, the amount of lung inflation or expansion for a given change in interpulmonary pressure. Now in the respiratory system, in a peripheral muscle like a bicep, we measure force output as the newtons, right? So the actual force. In the respiratory system, force is measured as pressure. So the more forceful a contraction, the more negative a pressure, right? So if you do a sniff maneuver, for example, you generate a maximum negative inspiratory pressure compared to if you just did, you'll get a negative pressure, but it's not particularly forceful. So on a maximum inspiratory contraction, you get a big negative pressure deflection. On basically a quiet inspiration, you'll get a negative pressure, but it's not going to be as forceful, or not be as great of a magnitude. So in the respiratory system, the work is really much dictated by the relationship between how much pressure we have to generate to move a given amount of air into and out of the lung. So it's pressure-volume relationships. Pressure-volume relationships is compliance, according to the elastic recoil model that we talked about several lectures ago, right? So the amount of lung inflation for a given change in interpulmonary pressure conforms to something that they call Hooke's law, which states that an elastic structure changes dimensions in direct proportion to the amount of force, respiratory system pressure, applied. So each unit of decrease in interpulmonary pressure generated by the inspiratory muscles causes an additional unit of volume to be generated. So in other words, as our lung, imagine this then, as our lung volume increases, and we begin to breathe all the way up near total lung capacity, is there a lot of elastic recoil up here? Yeah. Is there a lot of, is the rib cage trying to basically go back to a normal resting volume? Yeah. So if I were to breathe up here, my inspiratory muscles are being forced to breathe against all of that elastic recoil. It's as if we're trying to breathe against a really stiff balloon. So every breath that the inspiratory muscles have to do has to work against that elastic recoil. Okay, so this has implications for understanding the work and the oxygen cost of breathing. So as our lung volume increases, we get an increase in the elastic recoil on inspiration. This requires that the inspiratory muscles have to generate greater work, do more to move a given amount of air into and out of the lungs, and this will by necessity increase the oxygen cost of breathing. If you increase the oxygen requirements of breathing, but you don't change the inspired fraction of oxygen, how are you going to support the increased oxygen demands? How can you increase oxygen delivery? You can increase the amount of oxygen in the blood, or at a given amount of oxygen in the blood, what can you do to blood flow? You can increase it. So if the work of breathing becomes excessive, you have a potential, and I'm just prefacing this, you have a potential to actually steal blood away from the limbs. So we have to breathe in a way that's incredibly efficient so that the respiratory muscles don't compete with the limb muscles. Now, whether you believe in evolution or whatever it is that in the hierarchy of all things that are important, what do you think is more important? To prevent diaphragmatic fatigue or to prevent quadricep muscle fatigue? Diaphragm. Because you can live a comfortable life with a fatigued quadricep, but you cannot breathe with a diaphragm that's gone into failure. So in the hierarchy of all the things that are important, preference is going to be given to the diaphragm because you need to breathe more than you need to exercise. So let's come back to our balloon example here. So now the balloon are like the lungs, elastic tissue. We got this static pressure where the transpulmonary or the transmural pressure is 0. And as the balloon begins to fill, we basically, as the balloon volume begins to fill, we have to generate a greater distending pressure to overcome the elastic recoil. But eventually we get to the point where we have to dramatically increase the distending pressure even though we don't get much in the change in volume. there's so much elastic recoil, and the balloon becomes so stiff and rigid and non-compliant that you have to generate massive distending pressures just to move a little bit extra air into that balloon. So the stiffer it gets, the more recoil there is, the harder it is to distend. And you know this if you blow up a party balloon. It gets harder and harder and harder the more air that you blow into it. And as soon as you if you don't pinch the balloon, or you take your lips away, it just recoils onto you and it will empty. So it becomes more difficult. So under these circumstances, if you look, there's an optimal position kind of like to breathe on the most compliant portion of this volume pressure curve. So along this steep or ascending limb of this pressure volume curve, you can see that we get a relatively large change in volume for a relatively small change in pressure. So this is a good thing. You don't have to put much force into breathing to get a nice big breath. When the lung or the elastic structure is not stretched and recoiling. However, if you were to expand this elastic structure towards its limits, you would have to generate disproportionately large distending pressures to get very, very small changes in pressure. Now this is a very inefficient system. Requires a high cost to get very little reward. So if you consider that the work of breathing is really described by the relationship between the change in pressure, or the force that's generated by the inspiratory muscles, and the change in volume, you can appreciate that breathing, or when the lungs are, or when the elastic structure is distended and the elastic recoil force is very high, the work of breathing is very high. But if you're breathing along this more linear portion of this pressure volume curve, the work of breathing would be less. Because for a given amount of pressure, you would get more volume. So, that describes the relationship between pressure and volume. We're going to come back to that throughout the class. Now, we also need to consider airway resistance. So not only do we have the elastic recoil forces that we have to work against, we also have all of these breathing tubes that in and of themselves impose a resistance to airflow. So airway resistance is really the opposition to airflow caused by the forces of friction within the tracheobronchial tree. So we have all of those 23 generations of the airways. All of them impose some type of resistance to some aspect of turbulent airflow, right? So, the key to this is that I want you to think about this, and this underlined and italicized point is very important. At a given rate of airflow, okay, at a given rate or movement of air into and out of the lungs, this is very key. So think about this in the context of ventilation. Moving 30 liters a minute of air into and out of your lungs. What's required to support that task? Think of it almost like a constant load exercise test. To maintain 100 watts of power output, what happens to the muscle metabolic adjustments in the net drive hypothesis to maintain that force output when you increase or decrease the amount of oxygen in the cell? Now applying this to the respiratory system, to move a given amount of air into and out of the lungs is going to require a different amount of work depending on the amount of airway resistance. So at any given rate of air flowing into the lungs, the driving pressure, so basically the pressure, the difference between the interpulmonary pressure and the atmospheric pressure, that must be developed depends on the airway resistance. As a result, airway resistance becomes a very important determinant of the work and the oxygen cost of breathing. So, here we have a driving pressure. So let's say that pressure 1 and pressure 2. So pressure 1 is, say, the pressure generated by the inspiratory pump muscles. And pressure 2 is, say, the atmospheric pressure. Basically, it's the pressure difference between the atmosphere that's unchanging and the inspiratory muscles, which has to serve to decrease the negative intrapulmonary pressure to create airflow, right? So a given rate of airflow is described by the pressure gradient and the airway resistance. Now, airway resistance becomes very important because according to Poiseuille's law, we know that airway resistance is equal to airway length times by gas viscosity. So, say in the context of exercise, our airways are neither growing nor getting smaller. So that's basically a constant. The viscosity of gas that we're going to breathe is a relative constant as well. So a major source of changing airway resistance is by changing the airway radius. So bronchodilation and bronchoconstriction. Airway radius is raised to the 4th power. So this looks a lot like the control of exercising muscle blood flow, where very, very small changes in the radius of the feed arterioles resulted in very large or small changes in muscle vascular conductance. Exact same thing applies here to the airways. So we know then that a 50% decrease in airway resistance will result in a 16-fold increase in airway radius, which would occur during bronchoconstriction. If you have a friend with asthma, it's basically what happens. The airway smooth muscle is hypersensitive to allergies and triggers. So somebody that, they come over to your house and you have a cat or a dog and they're allergic to pet dander and whatever it is, all of a sudden they have an allergic attack. The airway smooth muscle begins to contract. The airway will constrict by 50%, which will, because it's raised to the 4th power, will increase airway resistance by 16-fold. So the idea here is that small changes in airway radius have dramatic impact on airway resistance. So in order to maintain a given amount of airflow into and out of the lungs, when airway resistance goes up, it makes sense then that you have to generate a greater driving pressure. So Alex, stand up for me for a second. So Alex is going to put his arm out. Maintain an isometric contraction, so keep it there. All right, so now, this is like the airway resistance, right? So I'm putting a little bit of pressure. So he has to do a little bit of work to maintain this contraction, as if the contraction is like airflow. Now, if I increase the airway resistance, as if I increase the resistance, he has to activate his muscle to a much greater extent to maintain the same contraction, as if he's maintaining the same rate of airflow into the lungs. So the idea there is that when you put a load on the system, you have to do more to achieve the same. If you unload the system, you have to do less to achieve the same. In the respiratory example, we're talking about the rate of airflow into and out of the lungs. So the alternative of this, or the opposite of that, then is that doubling the airway resistance will result in a 16-fold decrease in airway resistance. This will serve to decrease the work of breathing in order to maintain a given rate of airflow. So if we have a more dilated airway, the inspiratory muscles don't need to generate as much pressure to generate a given rate of airflow because the airways are more dilated. Less resistance or greater airway conductance. So we'll finish with this example and then we'll move on Wednesday. So let's consider bronchoconstriction. So you have an asthmatic attack, or let's say that you're allergic to peanuts and you have some type of anaphylactic response where your airway smooth muscle contracts, and that will decrease the airway resistance. Sorry, increase the airway resistance or decrease the airway conductance. So if the airway resistance goes up or the airway conductance goes down when you constrict the airways, you increase airway smooth muscle tone. The key here is, what do you have to do to the driving pressure in order to maintain a given rate of airflow? What do you have to do to the pressure gradient? You have to increase it in proportion to the increase in airway resistance. Now, if the atmospheric pressure is fixed at 760 millimeters of mercury, what does that mean that the inspiratory muscles have to do? They have to contract more aggressively to generate a bigger negative pressure to overcome that airway resistance. So then you have to increase the driving pressure in proportion to support the same rate of airflow. This is going to come at the expense of an increase of work of breathing. Now, Alice, on a 0 to 10, what was the first, when I put the light load on, was it 1? And then when I pushed down, it was 6, 7? So, to overcome that resistance will increase the perceived exertion. Have you ever run up a hill, ventilating a lot, and all of a sudden you become short of breath? It's no different than a skeletal muscle. You drive a skeletal muscle more, you recruit greater motor units, you activate the muscle to a greater extent, you become more short of breath. So this is why somebody who's having an asthmatic attack, who's wheezing, is saying, I'm really short of breath, I can't get air into my lungs. Because the inspiratory muscles are doing so much work to move a given amount of air into and out. Now, you take that same person who's having an asthmatic attack, and now you give them their blue puffer, their little Ventolin, a short-acting beta-2 agonist, which relaxes the airway smooth muscle and causes bronchodilation. So under those circumstances, if you decrease airway resistance, there you go. If you decrease airway resistance in order to maintain a given rate of air flowing into and out of the lungs, you can get away with a decrease in the driving pressure. Because the atmospheric pressure is unchanging, that means that you can get away with a reduction in the amount of negative pressure that the inspiratory muscles need to generate. Which then means that you have a reduced work of breathing. If you decrease the work of breathing, do you have to have, presumably, a lower oxygen cost of breathing? Because the work and the oxygen cost kind of parallel one another. So if you decrease the work of breathing, you would decrease the oxygen cost of breathing, which presumably if you begin to start moving along this concept, less work, less oxygen cost, a lesser demand for blood flow. Potentially less competition with the exercising muscles, particularly during very strenuous exercise when the cardiac output is already competing with the limb muscles for blood flow. So you can begin to see that where you breathe, if you breathe all the way up near total lung capacity, that has the potential to be inefficient because there's a lot of elastic recoil. And as well, if we breathe with a high airway resistance, if we don't have mechanisms that allow the airways to dilate, we have a circumstance where the work of breathing and the oxygen cost of breathing can become excessive very, very quickly. I'll explain why that's not the case for the majority of healthy individuals in subsequent lectures. All right? See you on Wednesday.